This is our fourth roundtable this week. The GST and I, as we said before, we want to pick subjects that you can bring back home with you as a leader with some tools to help your members. Certainly one of the most challenging things that we face in our profession is the behavioral health challenges. And far too often, we have that brother or sister in the firehouse that's, sometimes it's, I like to say, no one ever saw it coming. And then the other reality is, we all saw it coming. They're late for work all the time, missing runs, keep breaking out in handcuffs. All the signs are there usually. And we need to be proactive and cognizant and reach out to someone that you know's spinning out of control and trying to catch them early. It's kind of similar to cancer. Early detection and treatment is better than letting it spiral out of control. It's the difference between saving families and saving lives. And in our profession, I was taught that, every time we catch a flick or, a tough run that drops those endorphins or whatever it is in your brain that drives that adrenaline, that's a little scar on your brain. And they say that every run, every tough time like that, is a little pebble goes in a backpack in your brain. And at some point, those pebbles add up. And if we're not taking care of our brothers and sisters, like I say, that our mission starts in front of a church, no matter what puts them in that coffin. And the other part of this that we have to be very cognizant of is our retirees, when you leave the firehouse, even though they're always welcome back for the free coffee, a lot of times they don't feel a part of anymore. And that's something that try to track your pals that retired and left the job. Keep an eye on them. And what the IAFF has done has been phenomenal, trying to take this head on, which is the only way to do it. We have 8,600 trained peer support members across the IAFF now. The IAFF Center of Excellence has treated over 2,600 IAFF members and saved lives clearly. And today we have on stage here the pillars of how we deliver behavioral health assistance to our members. We have an incredible team here, some of which have been dedicated for decades to addressing this issue amongst our ranks. And we're very excited to have this roundtable, the wealth of knowledge around it. And I'm going to start off with Frankie Lidl. Frankie just retired as a captain out of the FDNY. Frankie was one of the first graduates of the West Point counterterrorism program. He's been all over the world studying behavioral health in the fire service. He's usually close to being our first boots on the ground on a deployment, and has been for decades, as long as I can remember. And we're very lucky to have him. He's a foremost authority in how not only behavioral health is evolving, but how we deal with it as firefighters. And in that same vein, our most steadfast pillar of professional knowledge, unlike us that just wing it in the firehouse, is Dr. Susie Gulliver. She is like a godsend. I love her. She's been someone that through one of my rabbis, Willie Osterguy, I've heard her name mentioned for 20 years now. And she has been doing research on us, trying to better how we take the science of treatment and make it to an application for our members, and has just really driven us from the, intellectual doctor world down to our one-on-one firefighter world. And when we made the jump into the Center of Excellence and a treatment facility for our members geared towards what is most often our plague, which is post-traumatic stress or co-addiction, our center needed that same type of level of education and expertise. And Dr. Abbey Morris is with us today, who's been running the show at the Center of Excellence now for, I guess, about 4 years, 5 years? 5 years. So she is a super talent, someone who is board certified in multiple disciplines related to what we need in our behavioral health. And we're very, very lucky to have her. And we appreciate you being here. And David is, Darrin Taylor. We just inked our contract with EHN, which is our health network here in Canada that has, I know we're going to talk about it in a minute, but I believe 7 centers throughout Canada that has tailored treatment for police, fire, and military, all that have that kind of same endorphin challenge that we endure. And what we're trying to bring to Canada is the exact same level of care, if not better. And obviously there's different challenges that we got to navigate, different systems of healthcare, et cetera. But Darrin is also one of the foremost authorities in Canada in treatment. He's run treatment facilities for years, and we're very lucky to have him and help us navigate the Canadian health system and make sure our members can get the help that they need. And Scotty Robinson's one of our own. Scotty's a longtime Cranston, Rhode Island president. He left Rhode Island, retired from the job, and came down to DC as one of our behavioral health specialists. Scotty's a firefighter through and through. Many of you remember the Station nightclub fire in Rhode Island. Scotty was on one of the first 2 companies that night where we lost over 100 people in a tragic, tragic fire. He immediately set up peer support teams, established behavioral health resources for not only firefighters in Rhode Island, but their families as well. And he's really done an amazing job. He's a rare talent for us in the IAFF, and we're so glad that you joined our ranks to help deliver and take care of our members. So with that, we'll get started. We'll get some, we'll start picking your brains. And I'll turn to the GST to start the convo.
All right. Thank you, GP. First question's for Brother Frank. And I know GP and I saw you lead a great delegation down at the condo collapse in South Florida. Thank you for that. And you've been involved with peer support from the inception. So can you tell us from how far we've come from where you started to where we are today?
It really is quite incredible where we've come. And in the last few years, we've built the largest network of peer support in the world, not only with first responders, in the world of peer support. Hundreds of our locals now have peer support programs. Some do not, and we still need to be concerned about them and reach out to them. It's difficult sometimes to build a program. Sometimes it's even more difficult to sustain that program. And we don't want to build programs reacting to a disaster. We want to build programs proactively, for sure. The peers that we have out there are out there reducing stigma. And the IAFF coupled with NBC a few years ago, and stigma is our #1 killer, is the fear to step forward. So now those peers are saying it's okay to step forward with PTSD, substance abuse issues, depression, whatever it is. You can step forward. That's a sign of strength, to step forward and get the help you deserve for these occupational illnesses and you need. The other thing that the peer program has been doing now is that we have all these trained peers all over the country. So when we do have a disaster, and over the last 2 years, 24 times the IAFF has responded to line of duty deaths, suicides, mass casualty events, natural disasters. We have so many boots on the ground that we can get there before the dust settles.
Frankie, same vein. We know, you just said it, we have the largest network of peer support, or people that can go out and try to break that stigma and make sure that we're trying to reach our members. Obviously that requires training. You don't want to send people in blind. What can we do to make sure we're constantly evolving with our peer support teams, that we make sure we're capturing the next best wave of how to deliver those services?
We're the best, but we can't rest on our laurels. There's no way we can rest on our laurels because a lot of people are still slipping through the cracks, and we see that all the time. And we have to make sure that the work that we do is based in science, that science and data tells the story, and that's why we work with people like Susie Gulliver. In the old days, we did what we thought was best. Now we're basing our work on the science.
All right, our next question is for Dr. Suzy. And you've been a trusted partner with the IAFF for a long time. And we know you're hard at work at our headquarters with our Behavioral Health Task Force. And you're keeping your fingers on the pulse. Can you tell us about your current research and your project collaboration with the IAFF?
Oh, thank you. It's an honor to continue to collaborate. The most exciting thing right at the moment is Project Combust, which is a survey of the membership. We opened it Friday, right, Scotty? Friday. And as of this morning, right before I came out here, I checked our numbers and we're just shy of 5,000. 5,000 evidence-based, psychometrically solid, which is psychobabble for we can trust the data, surveys completed already, which means that we have the pulse in a valid measurement for firefighters in the membership for how they're doing on psychological variables, but how they're doing in the workforce with their job satisfaction, with their sense of burnout versus non-burnout. So that's one study that I've had the honor of doing with you folks. Pardon? Oh, and the QR code is right up there, everybody. Bring our numbers up. The more data we have, the more confidence we have that we're really talking about how fire service is today, which is unheralded. There's no other data set like that. So that's one thing that we're doing right now. The second thing that we're doing right now that we're very, very proud of is our Project Access, which with the partnership with the IAFF, we were able to stand up a evidence-based telehealth treatment program all over the United States because with the pandemic, licensing problems dropped. And so with that study, we've been able not only to treat 84 firefighters with outpatient care, but to follow them and make sure that what they learned in treatment worked. And it did work, and it worked really, really well. So now we have a treatment program that can be trained to clinicians of every variety, and we know that the treatment sticks and that it helps across diagnoses. So not just one specific diagnosis, but across diagnosis. So those are the two most exciting things, but I could, you gotta give me the hook now.
Well, I'm gonna throw it right back at you because we're doing a lot. I mean, like Frankie said, I repeat it for the second time. We're the largest network probably in the world of people. We have our inpatient center for treatment. We have models for training clinicians to better educate them as to like who we are and what specific issues face us. We have some good things going. What do we need to be doing how can we improve that? How can we better strategically plan for the future to how to deliver these services?
So I think that's where the partnership between science and practice is so imperative. And that's what's unique for me is I'm not a firefighter, obviously, but getting to work with this profession means that it's left the ivory tower and it's out there. It's in the water supply. We've got behavioral health fluoride in the water supply now. And that, as long as the discussion continues, we keep assessing, we keep modifying, we keep assessing, we keep modifying. That's how we're going to bring it home so that we get prevention, and if we can't prevent it, we do early intervention, and if that's not enough, then we can hand people over to intensive care programs with follow-up that comes from the peer support membership, right? That follow-up is being brought back to a place where your wellness is checked in on. And that's a healthcare provider's dream, really.
Next questions for Dr. Morris. And Dr. Morris, you've been on the for 5 years with our Center of Excellence, leading it, working hard with our members, making an impact in their lives in their worst days. In fact, I know I've been told, probably everybody in here has been told by one person, that Center of Excellence saved my life. And for that, we all thank you. Now, after working with our members, what do you see the main issues threatening the health and safety of our members?
So I think when we opened the center, we were prepared for certain things. We knew we were going to see PTSD. We knew we were going to see depression, alcohol, opiate addiction. That we were prepared for. I think what we weren't as prepared for were the volume of people that were going to come to us with these really deep wounds from childhood. The really deep wounds from sexual abuse, from the chaos of childhood. That's a similar trajectory we see in so many of you guys. It's a similar story that we sort of didn't expect. You guys are onions, right? There are layers of you that have to be peeled. And we also didn't expect, I think, that I would be dealing with so much porn addiction, sex addiction, social anxiety, and for sure, I would say the number one biggest threat, sleep deprivation. I didn't know I was going to become a sleep doctor. I have to manage, doc, I can't sleep, but you can't make me sleep because I have to get up for my shift. So the number one thing that I'm dealing with my clinicians, with my doctors, is how do I have healthy sleep without ruining the issues that you all have to deal with not having any circadian rhythms whatsoever. So the number one threat to firefighters today is sleep deprivation.
I believe
Hands down.
Yeah, I can see where a lot of those issues, as you mentioned them, I didn't see them coming, but.
Yeah. I think, and the problem too with that is that you then have the subsequent prescriptions for testosterone and stimulants. So they all come to the center with their Vyvanse and their Adderall in hand saying, doc, I have to have this, but don't tell my wife because she's upset that I'm angry all the time. So you have the subsequent problem of the sleep deprivation and the subsequent prescriptions to deal with the sleep deprivation.
Sleep deprivation also relates to our cancer rates and our cardiac rates. So these things don't operate in silos. If you have sleep issues, your cancer rates are going to be higher, or your cardiac rates.
Absolutely. So like I said, if we talk about a threat, not just to mental health, we talk about a threat to firefighters and your life, that's the sleep deprivation.
Wow, that's deep. And it seems like it's an easy reach for me, how that would translate into our daily lives and the stress that it incurs, and how that translates into, relationship issues, addiction issues. Yeah. How can we do a better job of answering the call for in getting the services to our members?
So I would say that, we have the Center of Excellence. I'm biased. I think we're fabulous. And I love the fact that we're there. But I think we need to do more before we get to the Center of Excellence, before people have spiraled down to need inpatient care. What can we do for prevention? So let's prevent people from needing the inpatient care. Let's have healthier lifestyles. Let's have healthier eating. Let's have healthier social relationships, family relationships, healthier finances. I mean, all the things that give us wellness. And prevent inpatient care, healthier avenues to get to treatment. So outpatient care before you need the inpatient care. So I think if IAFF wants to give a new focus, let's not focus on how do we give good inpatient care, but how do we prevent so people don't need it.
Excellent.
All right. My next question is for you, Darrin, but for Dr. The sleep deprivation might have hindered our delegates this week as they were up pretty late last night.
Yeah, it looks that way.
Anybody up with that?
Darrin, as we welcome you to the IAFF sisterhood and brotherhood, especially here in Canada, we're thrilled to have a partner with you across Canada. And can you tell us why EHN Canada, has an edge on the treatment centers versus the other ones out there?
Yeah, certainly. Thank you. When I was first contacted by DVP Mike Carter over a year and a half ago and to ask if Edgewood Health Network was interested in building a partnership. You know, he laid out a vision of, providing a broad continuum of care, a full spectrum of treatment options, inpatient, outpatient, post-treatment, family support. We had to be able to offer it across the country, and we had to be able to offer it in English and in French. Once I heard that, my wheels began to turn. It really is a terrific fit. We have 7 facilities across the country, inpatient facilities, each of them offering, so many different programs, addiction programming, trauma programming, but also specialized programs for sex addiction, for depression and anxiety. We even have a highly specialized program for concussion and acquired brain injury treatment. So that's really, when we began to talk about that and the ability to offer it right across the country, and add to that our footprint in outpatient care, like Dr. Abbey was talking about, even prior to the pandemic, EHN had invested heavily and saw the need to bring intensive outpatient treatment as an option for early intervention. We were delivering it in person. We began delivering it virtually prior to the pandemic. And of course, when we were locked down and unable to conduct therapy in person, our ability to deliver virtual care so our patients could access addiction and trauma treatment from the comfort of their home if it was a clinical fit was fantastic. So we talked a lot about that, and then same with the post-treatment support. I'm sure Dr. Abbey would agree, it doesn't matter how good of a residential treatment program is, if we're not supporting your members post-treatment with aftercare groups, with the ability to connect with trauma therapists if needed, we're not gonna optimize outcomes. And the last piece was a commitment to family programming, understanding that when we're battling these illnesses and these conditions, it's extremely hard on our families. EHN has always had robust family programs, in-person, intensive, psychoeducational. So I guess what I would say to your members, to your locals, and to your teams that are helping members is this came up last night, is if you get contacted by a family member who's struggling and whose loved one is a member and their life is in turmoil, we can help that family member even before your member gets into treatment. So, it was the sort of bigger vision that Mike and I talked about early, and as the team was progressing, was really we're captivated with the idea of ultimately getting to a place where we could have a standalone bricks and mortar facility like they have in Maryland, just for firefighters in Canada. So in one of our early meetings, I brought our CEO in to sort of hear what we were talking about and to look into the vision. And his commitment to IAFF at that time was that, when the number of members coming to treatment supports it, he will build that facility if that's what the IAFF wants. And he means what he says. This organization has ambitious growth plans. We've got 2 new facilities in Western Canada opening in the next year. We've actually got a new trauma program opening for military veterans and first responders in Atlantic Canada in October. So we're doing our best in a vast country to meet the needs of people everywhere.
That's pretty robust, and I love how you address the family piece, because we look at all the different contributing factors. Sleep, we just talked about, finances. If you got a kid that's in trouble, for whatever reason, tough to sleep at night then too. And it's not just busy nights in the firehouse. Yeah. So if we can't get our family the help they need, we're gonna be in trouble. And it's a big piece of it. And I know up here in Canada, we have a different healthcare model than we do in the States.
Yeah.
And getting our members who need it access to EHN's facilities, how do we prove that. And then, of course, the other piece is how do we make sure that we can fund it and get them the resources they need from accessing it and funding it.
Yeah, that's a great question, and it's a conversation I have with organizations of every size. The solution lies in attacking it on multiple fronts. If we can support your efforts to speak with workers' comp organizations across the country, provide collateral data to provide input, we're happy to come alongside you in those conversations, because ultimately, I think what we all want is to see if IAFF members are on a workers' comp claim, that they are funneled to an approved program at an EHN facility. Certainly, we can help. We can help with that. The one thing I've learned that didn't surprise me is there's tremendous disparity amongst your locals across the country in their ability to access funding from the employer. It varies greatly. There's some locals in Canada, we've been treating their members for 2 decades. The employer is committed to pay for treatment. In many cases, sadly, that's not necessarily happening. I will say this, as discouraging as it can get when you're in the midst of a conversation trying to get funding for a member, we're seeing a shift in the Canadian workplace that I think it's important for us to leverage. Coming out of the pandemic, there's a lot of conversation about employers' willingness to do the right thing and address mental health and employee wellness. Our job is to be a resource, I believe, for IAFF and help make that business case to employers why it makes a whole lot of sense to fund treatment. Not only is it the right thing to do, in an environment where it's so challenging and costly to recruit and train, it makes fiscal sense. And honestly, what I've experienced already in the early days of our relationship is a willingness in your locals to call us if they're in a sticky situation. If there's anything we can do to expedite things with workers' comp, or to have a conversation with an employer, or to shorten up a wait list at one of our facilities, I'm even willing to, like I've told everyone who asked about it, let's get creative about length of stay and find a way to get to yes.
Yeah, the wait list is a massive piece. For those of us that have been kind of in the game a while, you're driving around with someone that wants treatment in your passenger seat, and you can't drop them anywhere, you can't take them home. We've been in those situations where you're like, if you go drop them at a firehouse, you don't know what's going to happen there either,
Well, I'm learning that one of the benefits of being part of a large network, listen, there's lots of hiccups and headaches of being part of a large network, but we can overcome the wait list issue. I've had situations where I've got someone in crisis in Ontario, our facility in Southern Ontario. If you have to wait 2 weeks and you're in crisis, it may as well be 2 months. It's extremely stressful. So we've been able to arrange escorts and travel companions and get someone in next day to a facility on the other side of the country. I come to work every day and do this. I want to see people get the help that I had when I needed help. I almost lost everything to addiction. And when I needed help was there for me. So there's nothing I won't do and my team won't do when someone calls to say, hey, listen, we got someone in crisis.
Amen. Thank you, Darrin.
Yeah. Brother Robinson, as a past IAFF affiliate leader out in Rhode Island and, with your peer instructor and a resiliency instructor, you have a unique perspective on what exactly affects our members and what they need. Now you're at IAFF staff working at headquarters of behavioral health specialists. What programs are you excited about coming down the pipe?
So first I got to apologize for my voice. It's the first time since 2018 since they sent our brothers and sisters, and it's been a great week catching up with everybody. So it's awesome to see everybody in person again. And I think back to Frank, when Frank was talking about being proactive and reactive to things. I remember, I think it was like 2007 when we had Redmond in New York, and you were running a roundtable with Ronnie Tapscott out of Phoenix, and I stood up as a new young labor leader, probably as thin as you are now, but a lot younger and had darker hair, and I didn't have the decades of experience that you had at the time, but I remember asking questions about what can we do as local leaders to build these, I was calling them a membership assistance programs at the time because peer support wasn't around. And I remember Pat Morrison was on the DS as well, and I remember those, this is a trickle-up organization, build it at your local level, and if it works really well at the state level, and then we'll look at it at a national and an international level. And that was like 2006, 2007, and then 2016 we start the peer program here, right? It's been one of the single greatest benefits that I've seen our members have access to. And I don't want to be reactive. I want to be proactive, and typically as affiliate leaders, we're always reacting. We don't have the time or the bandwidth to build programs ahead of our members' needs, but we're doing that here. It's simply amazing what we're doing. So coming forward, we have a recovery specialist program or a mentor program. So trying to help our brothers and sisters in the stations and our locals, our affiliate leaders, what can I do to support a member that's coming back from treatment and recovery, or that's having a difficult time and they're working in outpatient. So how do I create an environment that helps them get better? That's coming out really shortly. We're almost done with that. That'll be an online course. That'll be accessible through the IAFF behavioral health site. One of the biggest things that we found when I found as a local leader and a local peer designer of the programs was culturally competent clinicians. There just aren't any out there. I remember after the station nightclub fire, it was 3 years later, I was going to marriage counseling, and it was the first time that I talked about what had happened to me at the fire, and the fact that every time that I gave my wife a kiss, good night or goodbye, I just saw this last victim. And that was 3 years later, and I couldn't get past it. And when I was done telling my story, the clinician was bawling her eyes out, and my wife was bawling her eyes out. And I immediately thought, I'm alone. I got nobody that can help me. I got to do this by myself. And that was where I started my journey on trying to figure out, how do we find culturally competent clinicians that understand firefighter trauma and that can help us? And here we are. But, we have an online cultural clinician course that Lauren Kosk, my partner at IAFF headquarters, who's now the clinical program coordinator for us, which is so needed to have that aspect. And we're adding another behavioral health specialist to complement me. And we got John Nemick as the deputy director, and we're really building out the team. But now we have an online 2-hour course that provides continuing education for clinicians, which is huge to get them to buy into the information. And we're building an in-person live 2-day class that the beta is going to be in September. We're doing the first beta class in September in Concord, New Hampshire, at the Fire Academy there in the 3rd District. And then we're going to Kansas City in October with Local 42 and their 42 Cares program, which is a model for anybody that's looking to build an assistance program to reach out to Eric Rose and the team down in Local 42. And that's going to be the second beta class. And then we're going to take that information and hopefully by March have the continuing education component cleared up. And that's a live 2-day class where we do education on one day and how to work with us, which we probably could use a week to teach them how to work with us. But the second day is a fire ops course and exposing clinicians to what we do, just like we do our politicians, to get buy-in. And then we find out which clinicians really want to work with us or not, so that's an amazing course. We also have emotional regulation for emergency responders that's coming out of Suzy's shop. We're partnering with them to develop that online course. That'll be an advanced training for our peer program, our peer teams. And, as a peer instructor, some of the single biggest question is, what else is out there? What else can I learn about to do this job properly? And now we're starting to create content further than the peer support program. So more skills, more education so that we can really connect with our members. That emotional regulations class is just like, how do I take a person that's in crisis and then calm them down right then and there, and then get them to the resources they need. Now, not everybody has to go to a therapist right away. We don't have to get them into the hospital right away. Sometimes they just need some help regulating that emotion. The next one is we're working with Duke University. When I leave here, excuse me, when I leave here, I go back to DC, and we're gonna do filming for the role plays for an anger management course that we're working on. And that'll be open to every member of the IAFF. How do I control my anger? And you know, I remember myself, you know, anger was a way to be in control when I was losing control of everything. So what skills can I do to control my anger? And I think we all know brothers and sisters that are in the station with us. You're like, oh my God, this guy, like he's out of control again. And all he is, he's always angry with us. You know, he's always screaming, slamming stuff around. Well, let's create skills that they can use on their own. And so I'm super excited about that stuff. We're also, you know, what I've noticed in the conversation here is, how do we bring in other partners? We're talking about health and wellness and sleep deprivation, and we work with Fit to Thrive. I mean, we're creating a synergistic component in health and safety. We've even combined the whole division into health, safety, and medicine, right? So there's no, we talk about behavioral health because that's the topic that we're talking about, but it's really the health and wellness of our members. It's all inclusive. So I'm super excited to work with, partner with Fit to Thrive to work on that stuff, maybe even partner with AGP Breyer and the EMS division to create maybe a behavioral health EMS response, like how do we work with people in the streets for our EMS teams, but also the financial core. I've been talking to Kurt Becker, Susie McMullen, and the team over there to create, finances are a huge problem for us. And when we can't control our finances or we don't have access to adequate help for our finances, it's, again, loss of control, increased anger, depression, don't want to talk to my spouse about this, or I'm always in the station working overtime to keep up and pay the bills, right? So I'm working with them to create a one-pager that'll have an actual crisis number on board so that our payer teams, when they go out there, they have a resource. Hey, Scott, I'm having a problem with finances. Hey, I want you to call this crisis number that the IAFF has set up. They're going to help you work through these things. And it's not somebody going on the other line and say, well, what are your funds and where's your IRA and what do you have your for? It's not going to be like that. It's going to be like, what do you need from me right now to help you get through this? And that's a first, man. That's going to be some solid stuff. So I'm so excited.
I know. Abby?
So I would say in the future, looking at, I think you're absolutely right. Culturally competent clinicians are so important. But how about culturally competent psychiatrists, culturally competent primary care doctors? Because we have to start looking at the sleep deprivation issues, so they're not getting Xanax prescriptions for sleep problems. So they're not getting, like I said, testosterone prescriptions or Adderall prescriptions or Vyvanse prescriptions. I mean, I think this is a unique population. You all are a very unique population. And so I think we need to have culturally competent people who understand what you do, how you do it, why you do it, and so that prescriptions can be written. I mean, I think some of this is on us, on the doctors who don't understand what you do and are writing prescriptions in a way that's not responsible.
So that's a really good point. And one of the things that Lauren and I are super excited about is once this clinician course is done, we're going to start developing a list of clinicians that have taken this IAFF trained clinician course, right? And how do we keep them in that group, and maintain that list? Well, we want to create continuing education for them. And Lauren's excited about trying to maybe do a 2-hour webinar on prescription writing and what that looks like. So we can build out that whole division and on clinicians, and then really make them more inclusive with us.
And I would love to see you all going to your annual physicals and knowing what questions to ask. Right? Instead of saying, gosh, I'm really, really tired, and the doctor going, oh, well, it sounds like, and I'm having trouble concentrating, I'm forgetting things. Oh, well, it sounds like you need an Adderall prescription. Maybe you need to be asking different questions or giving your doctor different information so they have a fuller picture about what's really going on with why you're so tired or why you're a little distracted. Maybe it's not ADHD that started when you're 39 years old. Maybe it's your cortisol levels are really, really high from stress. Maybe you're not sleeping but 3 hours a night, and it's something else going on entirely. So helping the membership to understand how to communicate with doctors so that they get the right prescriptions in that 3.5 minutes that they get allotted to their primary care doctors or their psychiatrists would be a really helpful thing in the future.
That's one of the things that Dr. Wu, I don't even know if you know this, but we have a chief medical officer now at the IAFF.
Yeah, he's fabulous.
Yeah, so one of the things we're working on and collaborating with, and it is exactly that. Like, what do you go tell your primary care that because of your, would you call us unique? Yeah. Our uniqueness, we might want to tailor what we're doing on an annual basis to make sure we're not we're catching things and not chasing down the wrong hallway.
Right. I don't think it's that complicated, but I think there's a communication barrier, I think, between doctors and firefighters.
Right, and as it was articulated earlier this week, there's so much information out there that even a competent primary care physician,
Yeah.
What was it?
First, you have to actually go to the doctor. I'm looking at you, and you, and you, and you. You have to go to the doctor, and then you have to communicate properly with them, and they have to understand what you do.
Scott, you touched on something, so about creating a 1-800 number for our members that are in financial trouble. That's awesome, by the way. What about just nuts and bolts, affiliate leaders out here, members at home watching? If someone comes to you in trouble, and the bravest thing someone can do is surrender sometime and admit that they need a little bit of help, right? And we don't put fires out by ourselves,
Yeah.
What's one of our members supposed to do if someone reaches out to them and says, I'm in trouble, I need help?
Yeah. So first of all, I want to make it clear, because we're talking about behavioral health, and we are across the board, across North America, across the board, firefighters are if not the most resilient people I know. Right? So when we talk about building resilience, it's not because we don't have resiliency, right? We're resilient people. And that's the reason why we're in the profession we're in. We just want to give tools to help you maintain that resiliency, right? So as an affiliate leader, the worst question that I'll get if I don't have the answer is when I don't have the answer. But the worst question I get is, hey, who can help me? And if you don't have a plan in place or some place to turn, man, you feel like I'm a failure, that the program's not there, right? You all have resources, whether you have a peer program or not, whether you have an EAP or not, you have us at the IAFF, you have the Center of Excellence, and now we have EHN, right? So if I'm an affiliate leader and a member came to me and said, Scott, I need assistance with this, right? Because it's the most vulnerable time a member's going to come to us is when they're in crisis. We never like to ask for help. So if somebody's asking you for help, it's serious and it needs to be acted on then, right? So I would suggest if you have a peer team, I want you to reach out to the peer team member or the leader or whoever's running your peer team. If you don't have a peer team, and a lot of us don't, right? Not yet. I would reach out to your EAP. The problem with that is a lot of us don't trust our EAPs, right? We didn't. That's why we created the peer team. If you don't trust your EAP, reach out to us. Email or call the IAFF. I'll answer the phone. Lauren will answer the phone. We'll get you somebody in a really quick fashion. We'll spend our time focusing on that. No firefighter should have to wait for assistance or a doctor's appointment or anything. So we're working with people that are like that, And that's and the same thing with these.
Darrin?
I just want to add a bit to that. I got to say, the behavioral health team at IAFF is so impressive. I mean, I'm humbled at what I'm seeing in the effort and the coordination. I've been doing this work a long time, and the resources that are being built here and the apparatus in place is unparalleled. I mean, this is representative of best practice. But having said that, like you were touching on, it's incumbent upon all of us within this mechanism to ensure that this system is user-friendly for members. If it's easily accessible without stigma, it's user-friendly and perceived as effective, members look at it and go, wow, look what happened when so-and-so asked for help, got his life back. And that's what we need to create a cultural shift where like you were talking about, that leads to early intervention. Because if word gets around and everyone sees that asking for help is effective and user-friendly, then people will ask for help earlier. And I think like the treatment takes care of herself. We know there's good treatment there, but all the work that your team is doing, it's blowing me away. You know, it really is.
I think in that vein, it reminds me of, we had the bombing in Boston in 2013, and my files was deeply involved in it, so the department reached out. We did after action, meetings and stuff like that. But one of our guys, a particularly bigger, gruffer, more likely to pop your head off guy, come in proud as anything, saying, I went to see the Wizard. Department told me to go see them. I went to see the Wizard. I feel like $1 million. And all the other kids in the locker room were kind of like, if he went, maybe I should go. And it's the courage of that one person to come out and tell the toughest thing in the world, the truth sometimes, And I think that that's a big component of what it takes, the courage to tell the truth and be honest, which is not always easy. Frankie, in that same, in the same vein, like Darrin was talking about, could be somebody here that needs a little help, right? Someone might be listening going, it's time for me to ask for help. Like, what if someone's in the room right now? Like, what do we...
Well, we have two wonderful things that we're doing just today. Right after this meeting, we're going to be downstairs in room 107, and just come meet us. We'll continue the conversation. We can talk to you individually. We can talk to you as a group. And at 5 o'clock this afternoon over at the Westin, we're going to have a behavioral health group as well. So we've been doing that all week. We're going to be doing that at every IAFF gathering where we have a behavioral health group where we can get together and talk about these things that are no longer signs of weakness. They are signs of strength, that we can get together as men and women that do this work, that are resilient, like Scott said, and talk about the issues that are job hazards. Our depression rates are higher in the fire service, PTSD rates are higher in the fire service. Nobody told us that when we took the job. Nobody told us about what it looks like. Nobody told us about the treatment that's available. Now that information is there. There's no excuse not to access it, and we're available to you at the IAFF headquarters, which is incredible, the work that they do, and right here in Ottawa.
Thanks, Frankie. Go ahead, Scotty.
I just want to add what Susie's group is doing with the Combust survey. So for all the leaders out there, I've been out on the tables, right? I've sat there and listened to it like, all right, another survey, like, all right, if I get a chance, I'll do it. It's 12 minutes, right? And when we were building this survey, we're like, firefighters are not going to spend 12 minutes doing this. And I'm like, they're going to spend 12 minutes doing this. And here's the reason why. This is the first study or survey that we're going to put together that's going to correlate our staffing issues with behavioral health. So I think about my brothers in West Warwick at that fire, Station nightclub fire that we went and helped out at it. They had 2 firefighters get off the truck, people hanging out the door, stuck there, 2 guys, right? We had, not even luckily, but one of our members was there watching the band. He went around and pumped for those guys so that they could try to cut these people out of the doorway. 2 firefighters. So can we take the information out of this Combust study and say, look, if you have 2 firefighter staffing on your engines, the likelihood of them experiencing these types of behavioral health issues, post-traumatic stress, compared to a group that's got 4 firefighters on a truck, 5 firefighters on a truck, what their call volume is, it's going to give us as affiliate leaders the ability to go back to our municipalities, whether you have collective bargaining or you don't have it. You're going to be able to go back and you're going to have concrete scientific data that says, look, if you don't give a crap about disability pensions, post-traumatic stress presumptions, then don't even look at this data. But if you want to prevent all the money that you're going to end up spending on behavioral health down the road, start thinking about, is it cheaper to put a firefighter on the truck versus pensioning multiple firefighters off? All right, so take the study. It's 12 minutes. It's going to give you unbelievable amount of data to go back to your municipalities and negotiate.
Awesome. Well, listen. Sorry, Doc.
Anonymous. It's completely anonymous.
And it's completely anonymous.
And it's completely anonymous.
All right, good point. Good point. Listen, I want to thank everybody. It was a tremendous roundtable, a lot of information and knowledge you can take home with you. I just want to leave you with one thing. When I said on Monday, a lot of times, we focus on behavioral health, but in behavioral health is spiritual health. And I told you that I'm in recovery, and I do an AA meeting. We usually say a prayer every day. And the prayer that we use didn't come from me. It came from, there's about 80 or 90 of us on every day. One of our elder statesmen in this meeting retired off our job. Been off the job a long time. But he says the Michael's Prayer, which is Father Michael Judge, who's one of the chaplains for FDNY. His actual toe tag was 0001 on 9/11. And in his pocket was a prayer that said, Lord, take me where you want me to go. Let me meet who you want me to meet. Let me say what you want me to say and keep me out of your way. And I think if we're doing that, we're doing all right, because if you get to that point, you know, I'm sure someone's going to throw this in my face someday, but when you get to that point that you want to smash somebody in the face, if you just take a minute, take a breath and go, I was also taught this, don't talk to God like he's your judge, talk to him like he's your pal. If you say, hey, I want to smash this dude in the face, what do you think? He's probably not going to come down out of the clouds and go, punch him in the face, right? He's probably going to say, take a deep breath. He's having a bad day too. And when you come back to it, you'll probably be better off. So with that, listen, thank you to our round table, and we appreciate it. Let's try to take care of our members, you know?